Okay, welcome to the afternoon. We're just about 20 minutes behind, which is not too bad. We've got a great afternoon of clinical cases. She was going to start. We're going to do case number 3 first, which is Shiva Jarvis talking about endocrine complexity in pregnancy. We've heard it this morning, so over to you.
Thank you. Thanks very much for the invitation to speak on endocrine complexity in pregnancy, a twin journey with Cushing's syndrome. So an echo, might get. Keep going. So I'll be covering the case history, changes in the HPA axis in normal pregnancy, and it's a brief discussion of Cushing's syndrome in pregnancy interspersed within the slide deck. So I'm going to present the patient case of a lady who's 34 years old, Para 1, presents to a joint antenatal service elsewhere at 6 weeks gestation, has a BMI of 32, background from Romania, but speaks English well and understands appropriately, has a 10-year history of infertility, but this is a spontaneous conception. She has a past medical history of type 2 diabetes, essential hypertension, a diagnosis of PCOS, and in previous years, due to rapid weight gain, had had a previous gastric sleeve surgery. So looking at her pregnancy timeline for the first 17 weeks, hopefully that's clear of the types of interactions the patient has, which is fairly typical. I suppose in view of her type 2 diabetes, she was seen earlier at her booking appointment, had an earlier viability scan at 6 weeks. She has increased to her diabetes medications, is typically on metformin prior to this, and it's up to sort of increased Semglee. She has her eye screening. About 12 weeks gestation, she goes on to have her dating scan and found to have monochorionic diamniotic twins, MCDA twins. There's some dose escalation on her diabetes medications and the instatement of aspirin in view of her past medical history in terms of preeclampsia prophylaxis. We continue with her timeline around 15 weeks. She's had a VTE score, which shows that she scores 4 on sort of maternity assessment and she's qualified for low molecular weight heparin. At 18 to 20 weeks gestation, this is the timeline we're talking about, around 18 weeks, she's admitted. What should be said is prior to that, she'd been having problems with sort of walking, some generalized weakness, and presents with a severe right hip pain after climbing the stairs, and she has a hip fracture. She's admitted at 19 weeks gestation, she has a total hip replacement, and at that point, the local endocrine team are asked to review because she seems to have quite severe hypokalemia that's relatively intractable with peripheral potassium replacement during the admission. They note that she has Cushingoid features and a workup begins for hypercortisolemia, and an MRI adrenal is planned after biochemistry, all pretty quickly. There's no spoiler here, it's in the name, it's Cushing's syndrome. So let's think about that. It's rare, as we know, and actually in pregnancy still, it's even rarer. There are only 250 cases in the literature, with 100 of which have had active treatment in the literature. Diagnosis is challenging. Surgery overall has been performed in cases during pregnancy, as is medical management when you review the literature with metarapone, cabergoline, and others. And thinking about the etiology of active Cushing's syndrome in pregnancy, unlike outside of pregnancy where the complement is mainly perhaps Cushing's disease, you see an overarchingly increased number of sort of adrenal related Cushing's. So diagnosis, completely easy for this crowd, but basically the biochemical confirmation, thinking about 24-hour urinary free cortisols, late night salivary cortisols to think about abrogation of that diurnal variation, dexamethasone suppression testing, overnight, low dose, and so on. Thinking about the status of the ACTH, and that may be suppressed or normal in pregnancy, and then trying to differentiate the cause in orange. So thinking about the cross-sectional imaging and trying to locate the source. ACTH dependent versus ACTH independent. So let's just revisit the HPA axis, cortisol and pregnancy. So pregnancy is a state where there's physiological hypercortisolism. That's due to changes in the HPA with increased free and total cortisol. So in my fairly poorly drawn diagram, we can see basically in pregnancy, the liver will increase cortisol binding globulin synthesis. That will raise total bound cortisol. Think about the HPA axis and the usual situation. Having the placenta on board means that the placenta, as early as the first trimester, is churning out quite a lot of placental CRH, and that rises with advancing gestation and peaking eventually at term. And the placental CRH is similar to maternal CRH and will act in the same way on the pituitary. So we're driving increased cortisol production. And thinking about the effects on the fetus, we know clearly, we heard a fantastic talk this morning around 11 beta HSD, and thinking about that inactivation of the cortisol so that the fetus is not seeing the same levels as the mother. So yeah, and that's listed here, and that's 11 beta HSD 2 is expressed in the trophoblastic cells, ensuring that there's a lower level in the fetus. Here's a table adapted from Hamblin and et al., basically showing the different changes in total cortisol across the trimesters, increasing, as I say, with advancing gestation, CBG, as discussed, and then thinking about getting closer to term, post at the end of that third trimester, we see that there is an increase in free cortisol, and CRH reaches its peak. So 89 to 90%, just to reiterate the point, cortisol's metabolized, preventing fetal exposure. But at term, 25% of fetal cortisol is maternal in origin. So even modest shifts, there's a lot of work around prenatal stress and those sorts of things and the effects on the offspring. Modest shifts to that effect can lead to excessive cortisol reaching the fetus. And there's a large body of work outside of Cushing's and so on, thinking about that. So it is a very fine balance, even though the mechanisms are there to sort of circumvent the excess cortisol. So challenges in diagnosing and localizing the Cushing's syndrome in pregnancy. So this patient went on to have a 24-hour urinary cortisol and a late-night salivary cortisol. And I suppose in terms of interpretation, we know that in pregnancy, UFCs and that late-night salivary cortisol are likely to be 2 to 3-fold the upper limit of normal pregnancy, but obviously diurnal variation should remain. The ACTH in this particular case that was done around the time of that hip fracture and that hypokalemia at 20 weeks or so was suppressed. And again, thinking about some of those adaptations, we're not surprised to see that increase in cortisol, the CRH, as we mentioned, and ACTH in normal pregnancy. So I suppose the take-home point is a non-suppressed ACTH cannot reliably exclude an adrenal source. She went on to have an MRI adrenal, which showed a 44-millimeter well-circumscribed tumour. And thinking about MRI imaging in pregnancy, there's no contraindication there. There is some literature around trying to utilise ultrasound, and that wouldn't be an appropriate thing. Okay, so rising steroids, what it's all about, just thinking sideways a little bit. So endogenous glucocorticoids are clearly important for the onset of human parturition. CRH levels in the amniotic fluid and maternal circulation, as discussed, will increase as labour approaches. There's a decrease in CRH binding proteins, high free active CRH, and an ACTH spike just getting closer to term. And that's all about trying to stimulate fetal cortisol production closer to term. That's going to promote fetal lung maturation around the time of term and also have effects on placental estrogen synthesis, prostaglandins, and obviously kick-starting labour. But from an obstetric point of view, taking that in mind, excessive cortisol is associated with preterm labour, preeclampsia, and fetal loss. And there are direct effects on the placenta and its function from in vitro data. I'm not going to go through that. So let's kick back to the case. So we talked about the total hip replacement, the noting of her Cushingoid features. She gets discharged at 21 weeks from that centre, awaiting her MRI adrenal, which she needed to cancel. Not clear why that was. However, at 23 weeks, when she's now starting to have her fetal growth scans, it's noted that actually there are concerns. One of the twins basically has a raised uterine artery Doppler, a high resistance index, and that's concerning. There's oligohydramnios. There's fetal growth restriction less than the 3rd centile. She's also noted to have hypertension and needs to have rapid escalation of labetalol to 300 milligrams TDS, nifedipine 20 milligrams BD, typical medications that are used in pregnancy and impending preeclampsia. By 25 weeks, there's a major drop-off on the fetal growth. There's oligohydramnios. The uterine artery is now showing absent end diastolic flow in both twins. And actually, twin A, the one that we were concerned about earlier, has issues with the middle cerebral artery index as well. And then the patient is transferred over to our centre. And the rationale for that were really based on the fetal concerns and the need for early delivery on the fetal concerns and the fact that we have COTS at our centre. When she's admitted, we find her electrolytes look like this. She's got hypokalemia, she's hypertensive, her urinary PCR is elevated at 207. Clearly, we've got escalating hypertension, the significant hypokalemia. She's also fluid overloaded with preeclampsia in the backdrop, with severe FGR and MCDA twins. She goes on to have an MRI adrenal scan at 26 weeks at this point, and it's reviewed by our adrenal MDT. And you can see the images showing a left adrenal adenoma that's well circumscribed, looking benign, and that coronal imaging just showing the pregnancy. So there was a discussion at the adrenal MDT about benign versus, which was discussed. It wasn't looking concerning in terms of the actual lesion itself radiologically, and also looking at an MRI spine 2 years prior, we were able to see that she did also have an adrenal adenoma as well. So at this point, it was really driven by the obstetricians because of the fetal concerns. She's got her significant hypokalemia, and you can see listed how we manage hypokalemia. She needed central access. She was going to need an intensive care setting. At this point, she was in a labour ward HDU. She was fluid overloaded. We needed a CVP line with input-output monitoring. And her escalating hypertension, we rapidly increased her labetalol, nifedipine, and we did a PLGF, which is an indicative marker. If it's less than 12, that's suggestive of preeclampsia. Clinically, that was a diagnosis of preeclampsia. There were concerns around twin 1, and there was an imminent demise, all very much in real time over a number of hours, only sort of 18 hours into her admission at our centre. Imminent demise of twin 1 that was 481 grams, and it was likely because they're MCDA twins that could lead to demise of twin 2. So a decision was made for delivery on fetal indications, but also worsening maternal condition with the hypokalemia and severe preeclampsia. So the conversations that also took place around this time, just to sort of make it real, was would we give steroids for fetal lung maturation? I don't think I've got time, but would you? Can I do a sort of a ad hoc mentee with arms? Okay. There's some nods, no arms, it's okay. Right. So I guess these are legitimate questions, thinking about does she need that? Because thinking about the 11-beta HSD, because of the inactivation, or have we got enough steroids on board? And the obstetricians felt there was enough steroids on board for the twins and was not given extra steroids. And also concerns about her fluid overload and the retention. And normally, so I'll go back a point, if we're going to give steroids for fetal lung maturation in severe preeclampsia, we might try and do that over 24 hours rather than between 12 hours. So it's a slightly longer process. Didn't have that time with the fetuses. Places delivery, we need an experienced obstetric anaesthetist, the full MDT part of this. You needed post-op care in the ITU setting with the CVP line, etc. An experienced neonatologist on standby in awareness of the potential fetal adrenal suppression. We, at this point, were thinking about her Cushing's and treatment and thinking about surgical planning and referral to our endocrine surgeons, part of our adrenal MDT, and thinking about the metyrapone side of things, medically managing this in terms of that sort of florid signs, obviously exacerbated probably by the preeclampsia too. Patient delivered by Cat3 cesarean section at 26 weeks with a significant blood loss. The APGARs were stable, twin 1 needed more support at that point. The patient went into type 1 respiratory failure, needed her hypokalemia management, blood pressure control, required Optiflow for her chest, and actually after 24 to 48 hours began to stabilize. And she was commenced on metyrapone. Also importantly, she had ongoing anticoagulation. Typically post-cesarean section will treat for 6 weeks. She obviously had it for much longer. So just thinking about medical treatment of Cushing's syndrome during pregnancy and breastfeeding, thinking about the fetal effects, metyrapone crosses the placenta freely, and we know there are effects on fetal adrenal steroidogenesis and obviously the maternal side effects also. There are 4 cases of study of it being used in pregnancy. 1 started early in that sort of vulnerable window at 12 weeks gestation. And cortisol levels were low in infants immediately after delivery, but were much improved by day 3 and responded normally to a short-Actin test, with levels normalizing by 4 weeks. And although that short-term follow-up, there was no reports of normally developing babies growing appropriately. Thinking about metyrapone and breastfeeding, it passes into the breast milk in small amounts. There are 2 published articles for using breast milk assays of metyrapone and its active metabolites, and they peak at 30 to 60 minutes after an oral dose, but decline quite quickly thereafter. So in conjunction with our maternal medicine pharmacists, we sort of accessed a lot of that data, and I suppose a pragmatic situation if she wanted to express milk for the babies, given their critical state, and that was of importance. Even though we're extrapolating from a term infant, perhaps waiting for 2 hours after that dose of mitaropone, and then having her express milk might be a practical solution, because from the data, 0.1% of the maternal dose is in the breast milk from those studies. So that was sort of the recommendation. In terms of the other postnatal aspects of the care, so she would ultimately need definitive management with surgery, and there was planned OPD appointment with the endocrine surgeons who are very, able to interact with us very easily. We've talked about mitaropone, and that was commenced with monitoring with dose escalation with help from the endocrinology team, obstetric medicine during that postnatal pass, and our specialist endocrine nurse providing support. Thromboprophylaxis, obviously it's a hypercoagulable state. She had ongoing therapeutic dose low molecular weight heparin. We considered her bones and consulted our bone specialist colleagues in the trust, just in terms of thinking about ADCAL D3. Did we need to think about bisphosphonate, but obviously future fertility, and given that it's retained in bones for long periods of time, needs to be considered. And from a metabolic point of view, she quickly came off insulin, was on metformin, and actually was able to down titrate her blood pressure medications to enalapril and labetalol. She went on to have her adrenalectomy. She had a laparoscopic left adrenalectomy at 8 weeks postpartum, which confirmed the adrenal adenoma. And we can see here with the histology, the capsule of the adrenal at 2x image and a 10x image provided kindly by our histopathologist showed a bland cortical cell types with uniform round nuclei, no necrosis or mitotic activity, and features essentially suggestive of an adrenal adenoma. We've got no specific immunohistochemistry stains to speak of. And the patient now, as I understand, is recovering well and sort of thinking about steroid withdrawal sort of slowly but surely. So in conclusion, untreated hypercortisolemia, there are clear maternal risks, as we know, obstetric and fetal risks exemplified by this case with preeclampsia, a preterm delivery, and there are high rates of fetal loss, up to 30% in untreated Cushing's in the literature. The interpretation of tests is always going to be difficult, but I think if that suspicion is there, those tests need to be instated early on in the pregnancy. Surgical resection can be performed in pregnancy, usually at the end, sort of around the mid to end of second trimester. I'll wait for surgical colleagues to comment on that. Medical management we've discussed in terms of mitaropone use in pregnancy, and obviously there are newer drugs, but there's no sort of data around that for pregnancy or breastfeeding. And I'd like to thank you for your attention.
Yeah. Okay, any questions about that patient? A lot to take in there.
Very interesting case.
Yeah.
I just wonder, how was the hypokalemia developed after you started mitaropone? Because sometimes hypokalemia does not improve. How was this in this situation?
It was actually fairly stable to my best of my knowledge, wasn't it? It wasn't an issue, and actually we were quite able to increase the dose quite rapidly to begin with. She did start to feel some nausea and vomiting. She was also post-op. She was coming to the. I just haven't really done justice. I want to firstly thank the patient for allowing me to present the case. You know, such a harrowing situation, and it's ongoing for her. And the tiredness of coming in to visit your babies, often not on the same site. It really, can't really put into words on how that would be. But yeah. She tolerated it well. Back to your question on potassium.
Any other thoughts? In terms of using steroids in pregnancy with lung maturation, there wasn't enough time, so it's not relevant, I get. But the cortisol is, as you said, inactivated. So you want to use dexamethasone. The fluorine atom is the one that gets across. So if you really want to go for it, then dex would.
Yeah.
Okay. I think we should move on, actually. No? Okay. I think we can move on.
Thank you.
The time. Who's going next now? Is it
So,
you? Yeah. Julie,
So
welcome to
case-
start. Yeah.
yes, so let's go back to case one. So the next speaker is going to be
Okay.
Julia Gentesi.
Yeah. No.
And unfortunately, the spelling is autocorrected on the program, but it's actually correct on the online as well. So the title is going to be Many Decisions to Make, Lessons from the Basketball Court.
I just hold it.
There.
Aware. Is that okay? Can everyone hear me? Okay. So good afternoon. My name is Julia Argentesi. I'm one of the registrars from UCLH, and I will be presenting many decisions to make lessons from the basketball court. So our case begins with a 31-year-old gentleman who was found collapsed by his co-workers, and he was really quite unwell. He was sweaty and pale and clammy. He had shortness of breath and hemoptysis. So an ambulance was called and he was brought to us at UCLH. Originally from Philadelphia in the USA, he played competitive basketball, and he had no real past medical history of note, but he did have borderline blood pressures on sport medicals. So the A&E and ITU team quickly established that this gentleman was in multi-organ failure. He was tachypneic and hypoxic. CT chest showed florid pulmonary edema. He was hypertensive and tachycardic, and a bedside echo showed a dilated left ventricle with an ejection fraction of less than 10%. He was an acute kidney injury, and he had a lactate of 8.5. So at this point, the differential diagnosis was, could this be heart failure secondary to an embolic or ischemic event? Was it an autoimmune phenomenon or a vasculitity? Or could it be simply infection, as he tested positive for RSV on admission? So he was commenced on CPAP. He was given a big dose of methylprednisolone, and he was put on a GTN infusion, but this quickly had to be stopped because his blood pressure is just dropping. And he was subsequently put on a metaraminol infusion. So as part of his workup, he had a CT chest abdo-pelvis, and this showed a large, complex left adrenal mass. And a CT adrenal confirmed that this was a 4 by 5 by 7 centimeter nodule with indeterminate washout, and the right adrenal was completely clear. And during this admission, he had an FDG PET, which showed high uptake in the left adrenal gland with an SUV max of 6.1. And contemporaneously, an adrenal screen was sent, and his plasma metanephrines were in the thousands upon thousands. And his chromogranin B was elevated at 225. So at this point, they called an endocrine. And endocrine was like, this patient hasn't been very well. He's had chronic migraines and dizziness, and they diagnosed him with a pheochromocytoma crisis, presenting with a Takotsubo cardiomyopathy. So phenoxybenzamine was cautiously introduced, and they gave slow IV fluids. And they actually managed to turn him around within 2 weeks. He was discharged normotensive, 120/60, with no postural drop, having been titrated up on phenoxybenzamine, propranolol, and slow sodium. And his ejection fraction returned to 55%. So a couple of months later, he was listed for a left laparoscopic adrenalectomy, and with cautious pre- and intraoperative management by the MDT, the procedure was straightforward, and he was discharged of all antihypertensive medication. Leo was 7 centimeters with a PAS score of 9. And as you can see from his histology, it had classical features of a pheochromocytoma, and it aimed heavily for chromogranin. But the story just wasn't quite finished. So that FDG PET showed high uptake in the thyroid. And the question was, could this be thyroiditis, as he'd had RSV infection? On palpation, the thyroid was quite large and bulky. And an ultrasound thyroid indicated bilateral U5 calcified nodules in both lobes. And he also had metastatic cervical lymph nodes at the stage of 2, 3, 4, and 6. So a fine needle aspiration was done, and he was found to have medullary thyroid carcinoma. Calcitonin came back above 2,000. So not even 1 month after his adrenalectomy, he underwent a total thyroidectomy with lymph node dissection. And not all lymph nodes could be removed in their entirety due to some being quite deep within the thoracic cavity. So his histology confirmed medullary thyroid carcinoma, and it's calcitonin. And that FDG PET also picked up something in the liver. So with an SUV max of 4.6, a liver MRI indicated that this was metastases, and a biopsy confirmed that this was medullary thyroid carcinoma. Now, these lesions have been stable since 2022, since original admission, and there have been multiple discussions with oncology about how best to manage them, and it was determined that he should undergo an ablation at the Royal Free Hospital, as tyrosine kinase inhibitors are quite nasty and they have multiple side effects. So during all of this, genetics were sent, and this gentleman had MEN2A, rare oncogene mutation at 164, Now, he has a very complex family history. We don't really know much about his father because his father passed away from gunshot wounds in Philadelphia in his youth. So we don't know if there's a family history. So following all of this gentleman's plasma metanephrines never quite normalized, and his blood pressure became borderline once again. He had a CT adrenal, which showed a clear left adrenal bed, but on the right adrenal, there was a 2.8 centimeter nodule with features in keeping with a pheochromocytoma. Now, this gentleman really wanted to go back to some competitive form of basketball. So there was a long discussion about whether an adrenal cortex sparing procedure formed. And there were discussions with the MDT of pros and cons, and they decided, should it be possible intraoperatively, that's what they would do. And so he underwent a laparoscopic right partial adrenalectomy in September. Now, it was a little larger than they thought it might be. It was 4.8 centimeters with a PAS score of 11, but he recovered really well post-operatively. So in summary, we have a 31-year-old gentleman presenting with a pheo crisis with a Takotsubo cardiomyopathy. He's had a total left-sided adrenalectomy, but a partial right-sided adrenalectomy. He's got metastatic medullary thyroid cancer, for which he underwent a total thyroidectomy and has stable neck and liver metastases, and a new diagnosis of MEN2A. Currently, despite the partial adrenalectomy, he's on full steroid replacement therapy, and he's awaiting ablation at the Royal Free Hospital. He has returned to coaching basketball, and he attributes his physical recovery to our team, but the psychological recovery to the immense support group we have. And just to show you a schema of his progression, he's come in with florid pheo crisis, super high metanephrine, have started to downtrend a month later. They are now fully suppressed post 2 procedures. His calcitonin was grossly elevated. It has now halved post-thyroidectomy, but remains stable. And that's his ACTH and cortisol off prednisolone. This gentleman is heavily involved in philanthropic work, and he raises awareness to cancer. He has actually amassed quite a large TikTok and Instagram following, and that's his hashtag, which he likes to share. So our questions to the panel are: management of this medullary thyroid carcinoma. How would you go about tackling it? And would the panel have done the partial adrenalectomy?
I'm going to start, I can tell.
I'm sure here are people who are at least as smart. And so I would have both questions clear answers. I would definitely right now, as it is, just wait and see for number one and just wait what happens. Probably you need certainly treatment, but right now I would not do. And I would definitely be tried partial adrectomy in MEN2. I'm completely against in other types of pheochromocytoma, but MEN2, from my perspective, the likelihood that this is a malignant disease itself is so low that I would definitely have tried it as well.
Thank you. So it would be interesting to get the surgeon's view. We discussed this yesterday.
Our surgeon is not here to defend.
I think the surgeon just does what he's told at the MDT. You could say.
Yeah.
As far as the medullary thyroid carcinoma is concerned, I agree. I think that if the patient's not symptomatic, if the patient's having diarrhea, then you have a problem, maybe. Then you may have to consider doing something about the liver metastases. It's problematic because the liver metastases from a medullary thyroid carcinoma normally don't look like that. Normally they're miliary. So it's not a nice lump that you can go and do a liver resection on. As far as the partial adrenalectomy is concerned, it seems like a totally reasonable plan to avoid the patient being steroid dependent. So I totally agree. I have to say the CT you showed, you said it was 2.8 centimeters, but it didn't look that. And then surgery, it was 4 points.
Yeah, it was reported as
So-
2, but yes, it was much bigger when they
So
took
we'll
it out.
pass on that. But yeah, I mean, I think that if you can do a partial adrenalectomy, and I think the nomenclature used is correct rather than this concept of cortex sparing, because I don't think it exists. So a partial adrenalectomy preserving normal adrenal tissue in MEN is a reasonable idea because malignancy is uncommon.
And also we can assume most medullary tissue was taken because they're suppressed now.
Yeah.
So yeah, they probably did spray football.
Thank you.
Go ahead.
Yeah, no, he's my absolute favourite patient, and he's done. I mean, it's a lot of patients we see have life-changing presentations, but this literally, it really has been for him, and he's done massively well. We talk about everything. He supports the Eagles, I support the Chiefs. So, but apart from that, we get on really well. If you don't know that reference, we can chat later. I suppose my question, Julia alluded to, is really about the Mets and the liver, because our MDT is suggesting, oncology MDT is suggesting go for ablation, but he's had such a rough ride. They're totally stable. I'm kind of inclined not to do anything while it's stable. And Martin, is that the kind of perceived agreement? For what it's worth.
We would do the same, wouldn't we? It's just watch the calcitonin and.
Thank you.
Yes.
When it jumps.
And also when you've got other options, if you
Yeah.
it's obviously got a red mutation, and so the dark red inhibitors are very well tolerated compared to
Thank you.
Okay, thank you very much. Shall we move on to the next case, then? Which is, get the order now, it's going to be Sonam Sharing here. Let's see if I can get your slides up while we're waiting.
How do I turn this on? Have I failed?
Is it there? Where am I? Oh, there. Oh, here, here, right side. This one. They both work. That's better one. You have that last week.
Thank you very much. My name is Sonam. I'm one of the endocrine registrars at Parts Health. Today, I'm going to present a case titled "A Change of Direction." So this is a 64-year-old gentleman, got a history of metastatic Leydig cell tumor, diagnosed in 2021 with intra-abdominal nodal metastasis, for which he underwent left occipectomy in 2021 and retroperitoneal lymph node dissection in early 2022. He had a nodal recurrence in 2023, for which he had a redo RP-LND 2023. He had a further nodal recurrence, for which he completed 3 cycles of BEP, bleomycin, etoposide, and cisplatin chemotherapy. Unfortunately, he had a further progression with liver metastasis and was referred to Bart's Oncology for further management. And at Bart's, he received a first cycle of IPO chemotherapy. During that time, he was found to have a severe resistant hypertension and hypokalemia, and was referred to endocrinology further. So when we saw him, he gave a history of 9 kilograms in weight gain, easy bruising, difficulty climbing stairs, facial swelling, worsening hypertension despite treatment. He's also got a history of type 1 diabetes, was quite well managed with high-grade closed-loop. On examination, he was looking what? Facial plethora, hypertensive, multiple widespread bruises, abdominal stretch mark, laparotomy scar, severe proximal myopathy with pitting edema. Lab investigations, he had severe hypokalemia with metabolic alkalosis. Random cortisol was elevated to 1500 nanomoles per liter with midnight cortisol of 1300. And ACTH was suppressed to less than 3 nanograms per liter. And endostinedione was slightly elevated at 12.5 nanomoles per liter with normal DHEAs. We proceeded to CT adrenals. As you can see here, images, both right and left adrenals are looking very pristine and clear, no nodules, no hyperplasia. And also you can appreciate the disease burden in the liver there. Just to recap, he's a 64-year-old chap with metastatic Leydig cell tumor. Now he's got new severe SDH independent syndrome with normal adrenal bands. our hypothesis at this point was, could the excess cortisol production coming from metastatic lytic cell tumor? We knew that SCC was very, very unlikely in this patient, given normal. In order to help our hypothesis, we have proceeded to biopsy from liver mets, also an advantage of a new functional imaging called CT scan. So Adrenal CT scan is how this, the way it works is basically it's a functional novel imaging, primarily used for the investigation for primary ultrasound. So it binds to the enzyme here called CYP11B1, which converts 11-deoxycortisol to cortisol, and CYP11B2, which converts corticosterone to aldosterone, which are the final steps in adrenals. So in patients who we image for primary aldosteronism, dexamethasone is given to suppress this pathway so that whatever we see due to overactivity of this pathway, overexpression of CYP11. However, in our patient, we wanted to see the overexpression of CYP11B1 here, leading to excess cortisol production from the metastatic sites, and hence we have not given dexamethasone here. So this is the scan. You can see increased uptake in the abdomen, and you can see here the diffuse image, increased uptake in the liver, and also in the intra-abdominal node. Interestingly, there was no uptake in the adrenal glands, which is suggesting that all the excess production of cortisol is coming from metastatic sites due to expression of CYP11B1, change of cell character. Now I'll hand over to my colleague to talk about GEMS.
Thank you. So to get a tissue diagnosis, he had a liver biopsy, and the sample that went to the pathologist in the hospital showed that there were that this was indeed a metastatic Leydig cell tumor with the same high-risk features that were seen in primary tumor, E67 of approximately 40%. The cells were positive for SF1, inhibin, and calretin, as you would expect with Leydig cells. But interestingly, they were CYP11B2 negative, which particularly in the context of the positive findings on the CT scan, does imply that there is CYP11B1 expression in these cells. CYP11B1 is not, we don't have that as a working immunostain in clinical practice at the moment. And so we were able to, however, get a portion of liver biopsy to take to the university, look into some adrenal markers, including CYP11B1, CYP17A1, SOAT1, and DLK1. So as I'm sure you can all tell, this is clearly a Leydig cell tumor. They're polygonal cells with a granular eosinophilic cytoplasm. And you can see that this is mirrored in the biopsy of the liver metastasis, which hyperchromatic nuclei had evidence of some mitoses. And this is the immunostain for CYP11B1 in the liver metastasis, showing that there is positive expression. It is a temperamental antibody, so you'll see compared to some of the other ones that it's not quite as clear cut, but I think be happy to agree that that is positive. Interestingly, in the primary tumor, there were some clones that expressed CYP11B1 also areas of the tumor did not, and indeed patients' cortisol was not measured at the beginning, but there's certainly no clinical features of Cushing's at the time of the primary surgery. In terms of other adrenal markers, CYP17A1 was strongly positive, both the primary and the liver metastases. I've tried to include some stroma in all of these magnified images so you can see that that's a sort of intrinsic negative control. Interestingly, SOAT1, which is the molecular target of the drug mitotane, also strongly positive, both the primary and the biopsy, and also DLK1, which is not supposed to be positive in Leydig cell tumor. And in fact can be used to differentiate them from parts, normally DLK positive, was strongly positive in both the primary and in the biopsy. Now, we took advantage of an ongoing collaboration with David Taylor at King's to get a sample of his serum sent for a serum steroid panel. I was terrified of answering questions from Viva. I don't think she's in the room, so I may have dodged a bullet on that one. So this shows a profile where the cortisol is raised, but also the 11-deoxycortisol is raised, much higher than you would expect normally. And this is in keeping with a sort of fingerprint that David has previously published about, which is more in keeping with adrenal cortical carcinoma. Now, full disclosure is that this is a case that was evolving in real time. It was a man who was very sick, who did require some treatment with tyrosine in the build-up to these investigations. So it's not a tyrosine naive sample. However, it had been held for 40 hours prior to this in advance of the CETO scan. And David has helpfully explained that normally the metyrapone effect you would see on this profile would have much higher levels of 17-hydroxyprogesterone and also 11-deoxycorticosterone as well. So we take this with a pinch of salt. It certainly would look like it's a serum profile more consistent with adrenal cancer rather than expect from an Leydig cell. And just to go back to our embryology, the adrenal cortex comes from the coming together of some coelomic epithelium and the intermediate mesoderm to generate the adrenogonadal primordium. And this is more clinically relevant to most of us here with adrenal breast tumors, where we see sort of adrenal remnants in the testes. And so the adrenal cortex comes together and comes off this and then envelops the ectoderm, which composes the medulla. So the working hypothesis here is that there has been a de-differentiation from these Leydig cells, and that they are now redifferentiated more of an adrenal phenotype, expressing and causing.
Thank you. In terms of management, we have started him on metyrapone with very excellent response to Cushing's features. And after discussion with our oncologist, he was commenced on mitoten. Now he's on 1 gram 3 times a day. And our colleagues from oncology have started him on second-line SEC treatment chemotherapy, gemcitabine and capecitabine. And has almost achieved the therapeutic mitoten levels, as you can see, between 14 to 20 milligrams within 3 months of treatment. And we are really surprised by this scan, really, the treatment response within 4 months interval of treatment. As you can see, there's almost complete resolution of liver and nodal metastasis here on the scan within 4 months. Very, very surprising and excellent response to the treatment. He also achieved very good biochemical response, as you can see by rising STH. In fact, now he's hypoadrenal with STH of 230 nanograms per liter recently. So metyrapone was stopped, started on fluorocortisone with the dose. In summary, he's a 64-year-old gentleman with metastatic Leydig cell tumor, refractory to conventional treatment, redifferentiated reduced cortisol, started on mitoten in second-line SEC treatment, excellent disease response, completed 6 cycles and remains on mitoten. Now hypoadrenal on replacement. We plan surveillance CT scan next week as he has completed chemotherapy. And we are also planning for a follow-up CT scan. Thank you.
Thank you very much. Any questions? Oh, with
Comments?
Very cool case, indeed. I just wonder, so even Leydig tumor cells actually respond very well to mitoten. Therefore, indeed, I wonder, independent what the final diagnosis, which is if not mitoten alone, would do the job. So considering maybe on long term just have on mitoten, but.
oh yeah.
Hi, this is not my case. This is the very clever Professor Drake's case, but I'm the only one that's here today. So we did think about that, and he's in a centre at Barts that looks after lots of testicular tumours and gonadal tumours. And the oncologist that saw him had was not comfortable to just treat him with mitotane, as you might imagine. And the treatment in terms of the gemcitabine and the capecitabine came from a rationale of first-line ACC treatment would involve platinum, effectively, wouldn't it, and etoposide, which he had effectively already had in the treatment of his original tumour. So that's why we went in with chemotherapy and mitotane. But your point is well made in terms of the staining that we've just seen. So that staining is hot off the press yesterday. So which does kind of go along with what you have just suggested about the use of mitotane in these tumours. Yeah.
Yeah, very neat case. You've stunned us into silence, I think. Has this been reported before? Because it's pretty common, isn't it? And yet I've never heard of it, and I'm ancient now. So is there any literature?
So there is a case report from, I think, Greece, like 20 years ago,
Yeah,
but they
it's
could
not
never
common.
prove
Mm.
that it was actually the lady cells that were producing. I think from what I can see, this would be the first real proof with the functional imaging. In fact, we managed to get tissue and a working immunostain for both of these. That's the unique.
And
Good,
just
go.
because I didn't go to the embryology lectures, do you think it is though some sort of adrenal rest? I mean, no, not at all. It's all just it's just de-differentiation that just happens to be an endocrinologist got involved rather than. So it's a bit of luck and clever Professor Drake.
That's my view. But my understanding is every cancer, the first cellular change is a de-differentiation. That first cellular change is a reversion to stem of sorts, and then the cancer
Right.
develops from that. Now, once you've got widespread metastases, you're having increased mitosis and therefore increased mutagenesis. Therefore, the likelihood that that may happen is much farther. There's much less of a leap for it to go back to something that's more stem and be redifferentiated. And some normal lady cells express cyclin B1 without it being functional anyway. So I mean.
And it is lucky because our offices are next door to each other. So the oncology office is next door to the endocrine office, which is why we work together so well.
Can I ask a quick question about the enzymes then? So do you think it's just the 11-HSD, or are these cells making all the enzymes on the pathway down from cholesterol to cortisol? Yeah. Is it reactivating cortisone?
We only know what CT
Yeah.
tells us, which the functional imaging will tell us that it's the 11, but we don't know is the answer. And I guess James's data again, as we've just talked about, shows us that we've actually got tissue now that stains for the enzymes, which is incredibly helpful and which we have never is not reported. So that's absolutely fantastic work there from James in the lab to get that out for us today.
On the serum steroid profile, there are notably lower levels of glomerulosa products, which
Right.
This is David. And interestingly, he hypothesized on that alone, is there a high level of 17 patient in? And you can see that the immunostain are really positive.
Right.
So everything is being
Right. Thank you. Any more questions from anyone? Now we've got a short coffee break now.